Good morning, everyone. Thank you for joining today. My name is Daniel Montes, and I'm a postdoctoral research fellow at Massachusetts General Hospital in Boston. It is my pleasure to moderate today's session titled Adrenal Imaging, and our invited speaker is Dr. Robert Berkenblit. Dr. Berkenblit is an associate professor in radiology and medical director at Montefiore Medical Center in New York. He completed his medical degree at the University of North Carolina and then continued his radiology residency at Montefiore Medical Center, where he works today. He then completed his abdominal imaging fellowship at Georgetown University. And currently, Dr. Berkenblit is a member of many radiological societies, including the ACR and RSNA. And most of his research is focused in CT, ultrasound, and MRI imaging of the genitourinary system and adrenal glands. Without further ado, I'll pass it over to Dr. Berkenblit. Thank you so much.
Daniel, thank you for that introduction. As you can see, I'll be speaking to you about adrenal imaging. Just to lay out how we're going to go, we'll start off with basics of CT and MRI of adrenal lesions, talk about the workup of adrenal nodules, and then look at the appearance of various adrenal lesions. As you know, the adrenals are a site of production of a number of hormones. Hyperfunctioning adenomas cause symptoms due to excess hormone production. Non-contrast CT may be adequate to localize a nodule for surgery. We'll get into greater detail about that later on. So just to start off, taking a look at the normal adrenal glands, you can see both adrenal glands in this patient, kind of this inverted Y shape or inverted V shape in this other patient. If we look at adrenal cortical hormone excess, how does that play out in the adrenals? Well, cortisol excess, the majority is related to ACTH excess production or excess presence, but about 20% are related to the adrenals, usually related to adenomas, but can be seen with carcinomas. Hyperaldosteronism is often related to adenomas, but can be seen with hyperplasia, or a very small percentage related to carcinoma. And in virilization conditions, most often related to hyperplasia, but can be seen with adenomas and carcinoma. So let's take a look at a case. This is a 51-year-old female with Cushing syndrome. The left adrenal nodule is seen secreting cortisol. Excess cortisol suppresses ACTH, and therefore the right adrenal gland atrophies. You can see how tiny the right adrenal gland is. Treatment of excess cortisol of adrenal origin, if it's an adenoma, the nodule can be resected. If it's hyperplasia, they may resect the more involved side, but may need to do bilateral resection with hormone replacement. Medical therapy can be tried, but has limited efficacy and can have side effects. Here's a 39-year-old male with a history of hypertension and decreased potassium. Biochemical workup showed elevated aldosterone. And here you can see this 6-millimeter right adrenal nodule. They went on for adrenal vein sampling, which localized to the right, and surgery revealed a 6-millimeter right-sided aldosteronoma. With adenomas as the cause for hyperaldosteronism, surgery almost always cures the potassium abnormalities. And with regards to hypertension, the patient response depends on the duration of hypertension and the likelihood of underlying essential hypertension. But post-op, most patients can reduce their multiple antihypertensive medications to 1 or 2. In the case of hyperplasia as a cause for elevated aldosterone, this is typically treated medically. And you can see that primary aldosteronism is the most common cause of secondary hypertension. Obviously, primary hypertension or essential hypertension is the most common cause of hypertension, but of those with secondary hypertension, primary aldosteronism is the most common cause. Adrenal vein sampling is necessary. In the past, a small nodule in a young patient, the diagnosis was made. But a number of years ago, data suggests that imaging alone is not accurate enough and adrenal vein sampling is required. If the patient is not a surgical candidate, then they just opt for medical therapy, as adrenal vein sampling is not going to change the therapy. Why is CT and MR unreliable for aldosterone secreting lesions? Well, adrenal nodularity is common in healthy patients. A solitary adrenal nodule in a patient over 40 with primary aldosteronism, is it even aldosterone secreting? Could it be a concomitant non-functioning cortical nodule, or could it be hyperplasia with the dominant nodule? Therefore, adrenal vein sampling is required if surgery is an option. Here we see a case, patient has bilateral adrenal nodules with elevated aldosteronism. The left-sided nodule is larger than the right. Adrenal vein sampling localized actually to the right, the smaller side, and right adrenalectomy cured the elevated aldosterone. What about non-hyperfunctioning adenomas? These are benign tumors that don't secrete excess hormone, often found incidentally and therefore given the clever name incidentaloma. They're seen in about 5% of the general population. 10 to 15% may be bilateral, and the term non-hyperfunctioning adenoma is really a misnomer, as about 15 to 20% may actually have subclinical hormone excess. Adrenal incidentalomas, if the patient has no history of cancer, virtually all are benign. There was a study a number of years ago looking at about 1,000 patients without a history of malignancy, and none of the adrenal lesions were malignant. What about adrenal metastases? Well, the adrenals are a common site for metastatic disease, but many oncology patients have benign adrenal masses. Remember, we just said about 5% of the general population have non-hyperfunctioning adenomas. Patients with primary tumor and no other metastasis, the adrenal nodule is more likely to be an adenoma. But if there are known Mets elsewhere, that adrenal nodule is more likely to be a Met. That's good statistically, but if you have an individual patient, you want to know their answer. MR can be helpful. You can see that adenomas on T1 show low signal and actually the increased signal on intensity on T2. But there's a significant overlap between the appearance of adenomas and Mets on simply T1 and T2 weighted imaging. And that's where chemical shift imaging comes into play. It's also known as post phase imaging or in and out of phase imaging. So excuse me as I go into a little bit of physics here, a little physics and math, but hydrogen protons in fat and water precess at different frequencies. You can see in this diagram, at some point in time, fat and water protons are aligned, and then over time, as they precess at different speeds, they become unaligned, and at some point in time become 180 degrees out of phase, and then become aligned again. Hydrogen protons are affected by their surrounding environment and may be shielded or deshielded. Hydrogen protons in fat and water have different surrounding environments. These changes from shielding and deshielding are termed chemical shift and measured in parts per million. If we look at the Larmor equation, we're able to calculate at 1.5 Tesla for hydrogen, a precession frequency is 64 megahertz. Hydrogen protons in fat and water have a chemical shift difference of 3.5 parts per million. When we plug that into the equation, we see the period of alternation, fat and water being in phase, is that magic number of 4.4 milliseconds when we look at 1.5 T. Hydrogen and fat and water are 180 degrees out of phase at half that time, or 2.2 milliseconds. So that's where those magic numbers at 1.5 T come into play, 2.2 being out of phase, 4.4 being in phase. Images can be obtained in or out of phase by varying the echo time. When in phase, the signal is additive. When out of phase, the signal is subtractive. This time is inversely proportional to field strength. So if you're using a old low field open MRI at 0.3 Tesla, which is 1/5 this field strength of 1.5 T, those times are 5 times greater. So in phase is 22 milliseconds, out of phase is 11 milliseconds at 0.3 T. And here you can see at varying field strengths, the echo times to be in or out of phase, and you can see the field strength dependency. At 1 T, fat and water are in phase at 6.6 milliseconds, but at 1.5 T at 6.6, they're ataphase. So what are the clinical applications of chemical shift imaging? Well, if fat and water are in the same pixel, signal intensity will drop out from in to ataphase. Adrenal adenomas have a relatively high amount of intracellular fat and water. Metastatic lesions typically do not have much of a fatty component. With in and ataphase imaging, we're evaluating microscopic fat, not macroscopic fat. So adenomas, if they're lipid rich, will lose signal from in to ataphase. Remember, fat and water in the same pixel on ataphase loses signal. Metastatic lesions tend to lack fat and therefore maintain signal from in to ataphase. Atypical adenomas exist. Up to about 30% of adenomas may lack adequate intracellular fat to behave in this typical fashion, and these are the so-called lipid poor adenomas. There are cases of adrenal mets that are lipid rich, for instance, clear cell type renal cell carcinomas and hepatocellular carcinomas may be lipid rich. What about macroscopic fat? Microscopic fat is what we're looking at in the adrenal. Macroscopic fat's different, and we can see it here in this large chunk of retroperitoneal fat from in phase to ataphase. That signal intensity is maintained. There's not enough water there to cause signal loss. But when we look at the interface between water-rich spleen and fat, at that interface, we get the chemical shift artifact. So let's take a look at some cases. This is a 53-year-old male with hypertension, and the exam is requested to rule out pheochromocytoma. We'll get into why this is a lousy history shortly, but let's take a look at this case. On T1 and T2, we see this 2-centimeter right adrenal nodule demonstrating intermediate signal. In phase, ataphase, there's marked signal loss. This is lipid rich. This is an adenoma. This is a patient with newly diagnosed breast cancer. Their CT scan showed a right adrenal nodule. And you can see T1 and T2, there's this 2 or 3 centimeter adrenal nodule demonstrating intermediate signal intensity. In phase, marked signal loss, ataphase. This is a lipid-rich adenoma. Here's a 70-year-old patient with endometrial cancer. Post-contrast CT showed a left adrenal nodule. They went on for an MRI, and you can see in phase and ataphase. There's chemical shift artifact at the border between the lesion and retroperitoneal fat, but the lesion itself maintains signal from in to ataphase. So what can we say about this lesion? We can say that it's lipid poor, but what does that mean? It could be a metastatic lesion, it could be a lipid poor adenoma, or it could be a lipid poor any other adrenal lesion. Because it was going to alter how this patient was treated, they went on for biopsy, and this turned out to be a metastatic lesion from the patient's endometrial cancer. Often the assessment of signal loss can be made qualitatively, just looking at the lesion. As you saw in those couple of cases I just showed you, the signal loss was quite apparent just looking at it. But you can do a quantitative measure calculating the signal intensity index. And if that index, as you see the equation here, is greater than 16.5%, you're dealing with an adenoma. What about fat saturation techniques and their effect on the adenoma? Well, fat saturation affects macroscopic fat. A microscopic fat is what we're talking about with an adenoma. So adenomas, like I said, have microscopic fat. Fat saturation techniques suppress macroscopic fat. So we see in this patient, there's a 2-centimeter adrenal lesion. On in phase, we see that there's signal loss on the ataphase. This is an adenoma. We're dealing with in and out of phase with microscopic fat. But when we use fat suppression techniques, the macroscopic fat is suppressed, but the lesion itself does not lose signal intensity. So again, in and out of phase is for microscopic fat. Fat saturation techniques are for macroscopic fat. What about CT methods for evaluating adrenal nodules? Well, low density nodules are consistent with adenomas due to the presence of microscopic fat. A non-contrast CT, if the nodule measures 10 or less Hounsfield units, it's consistent with an adenoma. Similar to ataphase, about 30% of adenomas are greater than 10 Hounsfield units. They're lipid poor. Chemical shift MR may be helpful for lesions measuring between 10 and 30 Hounsfield units. Adenomas and non-adenomas enhance differently. Adenomas tend to enhance more rapidly and wash out earlier than non-adenomas. CT washout study evaluates how the adrenal nodule handles contrast, and the good news there is that it's not dependent on lipid content. Various studies have looked at various protocols, and what's generally accepted is a non-contrast, post-contrast, and a 15-minute delay to evaluate the adrenals on a washout study. If the non-contrast information is not available and by chance delayed imaging is done, you can do a relative washout study. So here we have non-contrast, post-contrast at about 70 seconds, and delayed at 15 minutes. Here's the equation to calculate an absolute washout. Here's the equation to calculate a relative washout if that non-contrast information is not available. So a lot of numbers on this slide, but what I want you to take away from it is simply that these studies are very good. They all have greater than 90% specificity, whether we're talking about non-contrast being 10 Hounsfield units or less, absolute washout of 60%, or a relative washout of 40%. So let's take a look at a washout study, how it's performed. This is a patient with lung cancer. They have bilateral adrenal nodules. We do non-contrast measurements, and they both measured greater than 10 Hounsfield units. Post-contrast and delayed, you see the Hounsfield unit measurements here. We plug those into the equation, and both measured greater than 60%. These are both adenomas. We can see that if we didn't have the non-contrast information, we can calculate a relative washout, which is greater than 40%, consistent with an adenoma. The ACR white paper in 2017 suggests that incidental adrenal nodule stability for a year or longer indicates benignity for indeterminate adrenal nodules. Adrenal adenomas can grow. In a study of 105 adenomas and 26 malignant lesions, about a third of the adenomas grew, but all grew less than 3 millimeters per year. All malignant lesions grew, but all grew greater than 5 millimeters per year. And growth is defined as change in the largest axial diameter. So we can kind of sum that up here with this algorithm for evaluating an incidentaloma. If we do a non-contrast CT or a post-phase MR and it behaves as an adenoma, we're done imaging. The patient goes for biochemical workup, and if functional, they tend to go for surgery. If that is not consistent with an adenoma, they can go to a washout study. If that behaves like an adenoma, they can then go on for biochemical workup and a functional surgery. If it doesn't behave like an adenoma, it's indeterminate and will require biopsy or follow-up. What about other adrenal lesions? You can see how pheochromocytomas and cysts show low signal on T1, and typically both are bright on T2. Pheos, however, will enhance, while cysts will not enhance. Myelolipomas and hemorrhage typically have high signal intensity on T1, depending on the amount of fat being present. And if there's enough macroscopic fat present, you'll have signal loss on fat suppressed techniques, while hemorrhage will not show signal loss. So why is that history that we saw earlier of hypertension, rule out pheochromocytoma, a bad history? Well, pheochromocytomas are a biochemical diagnosis. Imaging is done to locate the lesion. About 10% of adrenal lesions are extraadrenal. This is the so-called rule of tens. About 10% are extraadrenal, about 10% are bilateral, and about 10% are malignant. A couple other statistics to keep in mind with regards to pheo is that 10 to 50% of pheochromocytomas may be clinically silent. Also, only about 2/3 of pheos show classic signal, increased signal on T2. Something else to keep in mind about pheochromocytomas is they may masquerade as other lesions. They may have microscopic or macroscopic fat present. They may have variable enhancement and washout. An MIBG, a nuclear medicine scan, while it's nearly 100% has nearly 100% specificity for a pheo, has limited sensitivity. Something else to keep in mind with Pheos is that nodules with venous enhancement of 85 Hounsfield units or greater are more likely to be a pheochromocytoma than adenoma. At dual phase enhancement, if for some reason the study gets done as arterial and venous phase and the adrenal nodule is picked up, a nodule greater than 110 Hounsfield units in the arterial phase is most likely to be a pheochromocytoma. So Pheos show a great degree of enhancement. So let's take a look at a couple of cases here. This is a 31-year-old female with hypertension and elevated catecholamines. We see this 2 or 3 centimeter right adrenal lesion showing very high signal intensity on T2. And indeed, at surgery, this was shown to be a pheochromocytoma. Now let's look at their in-phase and out-of-phase imaging. Here's that same patient in phase and out of phase, there's no signal loss. What can we say about that, and what does that mean in this case? All we can say is that this is a lipid poor lesion. So what does lipid poor lesion mean? It means it could be a metastatic lesion, it could be a lipid poor adenoma, or it could be a lipid poor any other adrenal lesion, such as a pheochromocytoma. But with that history and that T2 appearance, it's certainly consistent with the pheochromocytoma. Let's take a look at a couple more cases. This is a patient with the right adrenal nodule. Here's the IVC, here's the nodule. Washout was calculated at 68%, which is very high, and you would think of an adenoma. However, notice how the enhancement is heterogeneous, and the enhancement in the venous phase was very high, 164 Hounsfield units. An MIBG study was positive, and this is a path-proven pheochromocytoma. So despite the high washout, it had features not typical for an adenoma, heterogeneous enhancement and very high enhancement. In this patient, biochemical workup was mildly elevated for pheochromocytoma. You can see this heterogeneous nodule near the IVC, MIBG avid, and this is a path-proven pheochromocytoma. Adrenal cysts, you may see post-traumatic, post-infectious, or congenital, and as expected for a cyst, show low signal on T1, high signal on T2, and no enhancement. Here you can see this lesion is low signal on T1, high signal on T2. And we see that the lesion on sagittal and coronal abuts and displaces the kidney as opposed to arises from the kidney. There's no enhancement in this. This is an adrenal cyst. Again, it's separate from the kidney. It abuts the kidney, but is separate. What about myelolipomas and hemorrhage? As you know, myelolipomas are benign, composed of varying amounts of myeloid elements and macroscopic fat. If there's enough macroscopic fat present, these may have T1 bright elements, and depending on the amount of macroscopic fat present, fat suppression techniques can be helpful. Hemorrhage, what's important to remember is they may mask an underlying lesion. These may evolve to become fairly cystic, and if there's subacute blood present, you'll see T1 bright elements. So here's a 75-year-old male on Coumadin. They have an MRI done, and you can see this lesion in the right adrenal gland, very high signal on T2, with marked signal loss on fat suppression technique. That's a myelolipoma. There's macroscopic fat present. They also have a left adrenal nodule with bright elements on T2 and T1 that do not suppress on fat suppression. And this was an adrenal hemorrhage. This over time resolved. This is a 60-year-old female with hirsutism. You can see there's this large mass above the right kidney. The liver lesions consistent with metastatic disease. When we look in the sagittal plane, here's this large mass above the kidney with large masses within the liver consistent with metastatic disease. This is a primary adrenal carcinoma. See how it's displacing the kidney as opposed to arising from the kidney. Primary adrenal carcinomas are typically larger presentation and therefore have poor prognosis. And why is that the case? Well, they're not efficient at making hormone. They need a large amount of tissue to make enough hormone to be symptomatic. If you think back on that half-centimeter aldosteronoma or the 2-centimeter cortisol secreting adenoma, those presented clinically with hormone excess. They did not present because of the nodule causing mass effector pain. Primary adrenal carcinomas are very inefficient at making hormones. They need a large amount of tissue. They need a large mass to produce enough hormone to be aware clinically of the presence of the hormone. So these typically present very large due to that inefficiency in hormone production. Here's another patient with a large mass in the region of the adrenal gland, heterogeneous enhancement. This is a primary adrenal carcinoma. What about this patient? They have a 3.5 centimeter nodule in the right adrenal gland. On the non-contrast, we see foci of calcification. Post-contrast, there's heterogeneous enhancement. They opted to follow their lesion, and at 10 months, the lesion is larger. This is now 5 centimeters. It's grown more than a centimeter in 10 months. This person then went to surgery at this point, which revealed a primary adrenal carcinoma. Let's take a look at a few unusual cases now. This is a 69-year-old male, had a CT urogram for hematuria, which revealed this 2.5 centimeter left adrenal nodule. On non-contrast CT, it measured 33 Hounsfield units. They went on for an MRI that showed no signal loss on a post-phase imaging, intermediate signal on T2, and enhancement on post-contrast. We can see T2, it's not bright, and it enhances, it's not a cyst. It's not bright on T2, not a typical Pheo. At a phase, there's no signal loss. It's not a typical adenoma. So what can we say? We can't rule out a metastatic lesion. Could be a primary carcinoma if larger. Could it be an atypical pheochromocytoma, one of those non-bright T2 lesions that I spoke about earlier? Could it be an atypical adenoma? Basically, at this point, it's indeterminate and needs further workup. This patient was not comfortable having this lesion sit in them for a 6-month follow-up, and they opted for surgery, which revealed a schwannoma of the adrenal gland. So I don't include this slide so that you include schwannoma. I'm sorry, I don't show this case so that you include schwannoma in your differential, but I include it to give you a feeling for the thought process, the imaging algorithm of how to go through the various studies that this person had and how to reach a conclusion that eventually led to surgery. What about this person? This patient had liver metastases from neuroendocrine tumor. You can see here on their preoperative MRI, this large lesion in the liver consistent of metastatic disease and a normal right adrenal gland. This MRI was obtained 12 days after the liver transplant as follow-up for the liver. And you can see there's this 2 centimeter nodule in the right adrenal gland. On imaging a year and a half later, you see that that nodule is normal. So what's going on here? Well, this is an adrenal hemorrhage related to intraoperative venous infarct. You can see that with liver transplants. I've seen a case on the left following a distal pancreatectomy. Here's a 23-year-old female with hypertension and abnormal catecholamines, but they had a negative MIBG. They were having pelvic pain as well, and a pelvic ultrasound showed a right adnexal mass. We see that here on T1. We see heterogeneous enhancement in this lesion on post-contrast. On the T2s, we see very high signal intensity in this lesion. They then went on for a FDG PET study, which was avid in this region. And at surgery, this was an extraadrenal paraganglioma. A few other interesting cases. This is adrenal lymphoma, bilateral adrenal masses that are large with retroperitoneal adenopathy present. Congenital adrenal hyperplasia. This is a relatively mild case imaging-wise. You can see nodular thickening of the adrenal glands bilaterally. It results from a deficiency of any one of 5 enzymes involved in steroid synthesis, most commonly 21-hydroxylase deficiency. Classic congenital hyperplasia results in low cortisol, low aldosterone, and androgen excess. Here's another patient with congenital adrenal hyperplasia, a much more dramatic case. The right side was resected because of hemorrhage, but you can see this markedly enlarged left adrenal lesion related to congenital adrenal hyperplasia. And this patient has what's called a fused adrenal. We see on the axial plane. Here on the coronal plane, we can see crossing midline. Fused adrenal glands, a rare condition, solitary adrenal glands spanning the midline. It's associated with several anomalies such as asplenia, neural tube defects, and renal abnormalities or diaphragmatic defects. It's thought to be related to a teratogenic insult in early embryologic development, very early in development. And here you can see in the same patient with the fused adrenal gland, abnormal spinal canal. So in summary, CT and MR are valuable tools in evaluating adrenal lesions. Non-contrast and contrast CT and MRI, including T1 and T2, and anaphase techniques can characterize lesions. Many atypical lesions exist that require follow-up or biopsy or surgery. Thank you.
Thank you so much for this lecture. Phenomenal cases and very comprehensive. We are going to move forward with Q&A. We have one question so far, and I would have another one by myself. So Dr. Mohammed Aid says, thanks for the great talk. How can we differentiate adenomas with lipid-rich and lipid-poor components from mets in adenoma, parentheses, collision?
That can be very difficult to do. If you're dealing with just an adenoma, for a typical adenoma, it's going to be homogeneous enhancement. With collision tumors, if you're seeing two different types of enhancement, you then need to think, could there be something more than simply an adenoma? Heterogeneous enhancement you typically don't see with an adenoma. Maybe there was hemorrhage in the past, which could cause it, but a typical adenoma should be homogeneous enhancement.
Thank you. And then my question would be, when you were talking about the assessment of growth to differentiate between mets and adrenal or adenomas, what is the preferred follow-up time to do the follow-up imaging?
Well, the ACR white paper says stability at a year will be consistent with an adenoma. Depending on the situation, I may get follow-up in 6 months just to make sure that things aren't, if there's a questionable lesion, to make sure that things aren't growing rapidly.
Okay, and another question, in a hypothetical setting where you find an incidental adrenal mass in ultrasound, what parameters would you consider to continue the imaging workup of these lesions?
If I see it on ultrasound?
Yes.
What's difficult there is ultrasound does not have any real specificity with regards to what that adrenal lesion is. So if you're finding an adrenal lesion on ultrasound, those typically will get worked up further with either CT or MR, depending on various clinical factors, patient tolerance, etc.
I see. And we got a follow-up question from Mohammed. He's asking, typical adenoma features, but larger than 4 centimeters. Do you dismiss or do you resect?
It depends on your urologist preference, but typically once you're over 4 centimeters, even if they're homogeneous, have features that suggest adenoma, once you're getting over 4 centimeters, you have to be concerned, and those typically get resected. Okay,
thank you so much, Dr. Berkenblit. We're getting a third question. What is your typical CT protocol for the adrenal glands?
Well, typically we'll get, if we're doing a washout study, we'll get a non-contrast set of images at 70 seconds with using standard contrast, roughly 120 mLs of contrast at 70 seconds, and then we get a 15-minute delay.
Thank you so much. We are not getting more questions. I wanted to thank you again from behalf of Health for the World for doing this, and everyone that attended as well. This was an excellent lecture. Thank you so much, and we will see each other hopefully soon.
Thank you.
Thank you.